doesn't work.
It's not showing up?
Nope.
Okay.
So what do we do?
Well, we're already getting started a little bit late. We've got a overweight, so we'll make do with that again today. Basically, thank you. So basically, starting up from where we did yesterday, looking at extracriminal side effects. This is something that you can remember correlating specifically with those drugs that have strong D2, dopamine 2 binding properties. So what you should be thinking about when you're going through these is, what drugs overall have those strong D2 binding properties. So primarily, of your typical antipsychotics, we know that that's a bigger problem with them because they all are going to bind to that receptor, which is why they're very effective for the positive symptoms, but not so much when we're talking about, say, our atypicals that bind to dopamine 2, and then we'll talk about it a little bit more about serotonin 2A blocking effects as well. So, and that's actually thought to be somewhat protective, which is why we think that the atypicals that bind to the serotonin 2A receptors, that they actually have less of a chance of this, that they actually help upregulate the dopamine in those areas that we would see the EPS presenting with in the nigrostriatal tract. So basically how you guys can remember it is the D2 receptor we need as an antipsychotic. Unfortunately, when we want it to work in the mesolimbic area, it's also going to block it in the nigrostriatal area, right? So our typicals, especially when they're blocking the D2 area, are going to have a higher chance of causing EPS. The idea of why our atypical agents are preferred is because they do have to bind D2 to exert their antipsychotic action, but because they bind it at serotonin 2A, all right, that in the nigrostriatal areas, that's thought to potentially increase the levels of dopamine and have less of a chance of these EPS side effects, all right? So when we're going through, again, EPS side effects are those abnormal motor movements. The one that's most pronounced, and you will often see when you're giving, say, an ion injection, if you have a patient that's agitated and you need to do that, is the acute dystonias. Now, that can happen, again, with any of our formulations, but particularly if you're giving an injection in a patient and you want to make sure you're not going to have them come up with an acute dystonia, that's going to happen in up to 64% of patients that are not prophylaxed with therapy to prevent that. So we're going to talk about therapy in a minute and what's appropriate for that. But basically, you should be thinking anticholinergics. Okay? So the acute dystonias that we talked a little about yesterday, they're painful contractions of the muscles. Up to 64% of patients, again, without prophylaxis are going to have that problem. Pharyngeal or laryngeal spasms can asphyxiate patients, so the fact that you think about what's going on with the muscles and exactly what it can cause those type of reactions is very dangerous. Okay? And then, when we're going through these other terms, basically these are types of acute dystonias, so trismus, spasm, blepharospasm, torticollis, and recticollis. So a lot of what you'll see when you're looking at these dystonias, if you want to look at all of these, is the trismus and glossospasm and the blepharospasm basically have to deal with the contractures of the mouth. So the patient with trismus may not be able to open their mouth. With glossospasm, it can be a contraction of the tongue. Okay, the blepharospasm, kind of going off with the same idea, being another contracture that, as you can see, being with the pharyngeal and laryngeal spasms, anything that's going to be going on in the mouth in this area is being problematic. Torticollis is basically if you see somebody's neck kind of turned to the side and they won't be able to move it, okay? And then recticollis is actually when it can be like turned back and up. So you don't really need to know the other terms. It's basically what you can think is the patient ends up getting very rigid, very stiff, and like ends up usually unable to move. There's other types of acute dystonias, but those are generally the more common ones. Okay. When we're looking at pseudoparkinsonism symptoms, so again, deep strokes are blocking the D2 receptors. Unfortunately, in more than just the mesolimbic area where we want to see it, but in the nigrostriatal, anytime you're blocking dopamine in the nigrostriatal area, you're going to end up getting potential for Parkinsonisms when you're blocking a certain amount of dopamine out of those areas. When we're talking about Parkinson's patients, overall, if they're losing dopamine neurons to present as Parkinson's, they have to lose about 70 to 80% of those dopamine neurons. And when they do that, that's when you start seeing the Parkinson's symptoms occur. So we've kind of thought the same thing. If you're blocking about 70 to 80% of the dopamine in that area, that you'll see those pseudo-Parkinsonisms start to present with our drugs. So that's kind of trying to find the balance of not causing those symptoms, but still being efficacious for our patients' psych issues. So, yes.
Do you mean 70 to 80%
blockage
of, okay, not permanent damage?
Right, no. So the drugs themselves, we're thinking that they're blocking about 70 to 80% of the normal dopamine that would be naturally in that area. So you take the drug away, that should go right back to normal levels, yeah. In terms of the pseudo-Parkinson. When we're looking at how to treat this, similarly, when we're thinking of Parkinson's patients, we treat them, their symptoms by giving them dopamine because it's deficient in those areas. We're obviously not going to do that in our psych patients because what's going to happen if we give them dopamine? It's going to exacerbate the psych symptoms, right? It's going to exacerbate the psychosis and the hallucination. So you're not going to treat this as you would say a Parkinson's patient with dopamine agonists. You're going to treat them with the anticholinergic agents, okay? Akathisias is a little bit different. When you guys are thinking EPS, a lot of the times people forget about akathisia. Akathisia is almost a feeling of inner restlessness, like you've got ants in your pants. Okay? If you have a patient who is sitting in a chair, okay, and you have akathisia, they're not going to be able to sit still. You'll notice them rocking back and forth. They will have to stand up, and they can't stop. They're going to keep on walking around. And basically, the only way to treat this that we know of is, number one, we're going to decrease the dosage of that medication, and number two, we're going to be looking at potentially using propranolol until we can get them stabilized to a point where they're not going to akathisia. So when you're looking at EPS, the first thing everybody thinks of is anticholinergics. It's akathisia that the patient's presenting with. A lot of the time, your doctors are going to prescribe anticholinergics, and that's not going to do anything. So I want to make sure you're taking that distinction specifically with akathisia. Okay? So when we're looking at the dangers of what this is, if you have EPS symptoms going on and you're not recognizing them, okay, the fear that we have is tardive dyskinesia. The little fig you see there is actually a form of tardive dyskinesia. Okay? If the patient gets these abnormal movements that can be permanent. And that's part of the scary effect of, we have a third of our patients that are going to develop EPS symptoms, and they go on over a long period of time. The longer you're exposed to a typical agent, the greater chance you have of developing the long-term side effect and potential tardive dyskinesia. So it's generally irreversible. There have been cases when the patient presents right away and it's recognized that they have been able to have some improvement, but I want you guys to think of it as irreversible overall. Okay, so the big key to this is prevention. There's no drug therapy that treats this overall, so you're going to want to make sure that you're recognizing it, you know what it is, you're letting the patients know what it is, and use that as your counseling point before you're going to start patients on that type of a therapy. Okay? When you're looking at, again, the atypicals in comparison, much less chance for this to occur, about 1 in 10 chance compared to typicals that this is going to occur. So I'm not saying 1 to 10 chance, like 1 in 10 patients using atypical. I'm saying 1 to 10 chance of those who are using typicals to develop tardive dyskinesia. So very, very low for our atypical agents. Okay? Is there any questions? Everybody okay? All right. When we're looking at our treatment again, you're thinking anticholinergic therapies with the exception of your akathisias. So typically, the 3 main agents that we'll see used most of the time is Benadryl, or diphenhydramine, Cogentin or benztropine, or trihexyphenidyl, which is Artemis. Okay, these are medications that you will see used in Parkinson's patients for, say, potentially tremor. But this is specifically if you're prophylaxing somebody when you're giving them one of our typical D2s with this agent, you should be able to mask the EPS that would occur. Now, I say mask because we want to make sure if we're giving, say, somebody Haldol and Cogentin, okay, I'm giving them Haldol as a major treatment, and then because I don't want them to develop EPS, I'm going to give them Cogentin. Prophylaxing them doesn't mean they may not actually be having EPS. It means if you take the drug away, that there's still the risk that that's going on and you're missing it. So a lot of the times in the acute care settings, we'll prophylax them until we get them stabilized, and we'll hopefully get them on a maintenance therapy where we're not using the anticholinergic therapies. Hopefully they're not having side effects and we don't need to continue it. And the other is that we switch them onto a medication that we don't need to have to worry about in the first place. The big problem with these is that, what do you guys know about anticholinergics? What's one of the side effects? Besides I always talk about it as anti-SLUD, anti-salivation, lacrimation, anti-urine, anti-defecation. I know you guys learned you can't pee, you can't see, something along those lines, right? You can't, what? Somebody help me out, because that wasn't my acronym.
It's not even
Okay, so can't think. Those are right there. It causes cognitive impairment. Number one, again, schizophrenia causes cognitive impairment, right, out alone. Then we're giving them drugs that can potentially do it. And on top of that, to mask the side effects, we're giving them drugs that are going to exacerbate it. So I told you guys one of the biggest barriers to patient care is the cognitive impairment issues. That third criteria for dealing with schizophrenic patients is the cognitive issues. So again, not really helping them long term. If you do have to use these, there are plenty of doctors that feel like, I'm going to prophylax them because if they get EPS, that's pretty darn scary, and that's going to make them non-compliant with the medication. And that's perfectly rational when you're starting the therapy, but our hope is overall, once you get them stabilized, you're hopefully tapering them off the anticholinergic medication or onto something that we don't need to worry about in the first place. Okay?
Did I understand you right when you said about the anticholinergic that it masks the EPS? Doesn't necessarily meaning like you could be going through products and not know it, and then
yeah. So for example, when we get to the drugs, I was going to mention to you guys, one of the things that's characteristic if somebody has Parkinsonism traits because of our lower our Haldol, for example, what we would consider our in terms of potency, it's probably got the greatest chance of causing EPS. It's actually known as having the Haldol shuffle, where patients get the Haldol. It's known as the Haldol shuffle, similar to what you see again in a Parkinson's patient. Okay, if I'm giving them Cogentin so they don't develop, if they've got the Parkinson's shuffle or the Haldol shuffle kind of going on, I'm going to basically give them Cogentin. That's going to go away, but knowing that the underlying there, if I'm not giving that, they're probably experiencing some level of that, and that does lead to much greater risk for developing that kind of dyskinesia because EPS is actively occurring. So, good question. Okay, so mentioned the 3 anticholinergics. The third one there you see the trihexyphenidyl or Artane. That one's not used probably as much as the first 2 you see there, just because of the fact you have to usually dose that one 3 times a day. Not that you wouldn't sometimes if you had active EPS with some of the others, you could potentially, but this one's almost always at least 3 times a day. So the Cogentin's got a little bit longer half-life. You see that one used a little bit more, and the Benadryl as well. So the propranolol, just have an idea again, that's akathisia is the only reason, again, the first thing you're going to do is decrease the dosage before you're going to expect to see that. So, which of the following is not an anticholinergic side effect? So how many people say A? Constipation. B, dry mouth. C, urinary retention. D, cognitive impairment. E, all of the above? Yay! Okay. So yes, they're all anticholinergic side effects. A lot of the time people forget about, for whatever reason, again, that cognitive impairment. Okay. Cognitive impairment? The EPS side effects? They can happen within the first dose of the medication. It's usually going to happen, when you're giving the peak of the drug that you'll see them occurring. I can tell you if it's an acute dystonia, we'll see that particularly more so when we're giving an IM injection. one of the things that's interesting, I'll mention when we're going to get to Haldol, is Haldol is very commonly used, for aggressive patients, and if they're hostile or if they're actively psychotic. You give them Haldol IM, and if they're going to develop an EPS reaction from that, you'll usually see that within the first 2 hours, typically 2 to 4 hours at most. It's not as common to see it outside of that. Not to say I haven't seen patients that have had that, but that might be when you're getting more of like a steady state level and the drugs hitting a little bit harder. So most of the time when you're going to see EPS develop, if it's that type of a reaction, it would be earlier. The pseudo-Parkinsonisms could be after you've been on therapy for a little while, so it really depends on which one you're talking about. But, Haldol IV, for those of you that don't like psych and are still going to go into, say, maybe critical care, okay, not that you wouldn't like psych, because psych is the coolest, but, if you were to, say, go into critical care, I guarantee you, you're going to have to deal with agitation and delirious patients. One of the reasons they love Haldol IV, which has got a separate issue we're going to talk about in a minute, is Haldol IV actually, you don't get EPS. Don't know why, but for whatever reason, as much as Haldol causes EPS, you give Haldol IV, it causes 0 EPS. Problem is that you get what you see listed up top there, which is more cardiovascular risk when you do that. So cardiovascular issues, arrhythmias, tachycardia, among our typical drugs, pretty common. Some of them, specifically thyroidazine, has been known to cause pigmentary retinopathy, so not something that we typically want to deal with in terms of the visual issues that can cause. Some of them can cause photosensitivity issues. You've got dermatological issues where the blue-gray skin is actually called Smurf syndrome. Some of them have the potential for causing that. Hepatologic, so your drugs that tend to be your high-potency drugs have a greater chance of causing transient increases in LFT. So as you can imagine, it might be actually hepatotoxic, and it's going to potentially have an effect like that on the liver. Be something you'll watch out for. Lots of hematologic issues that we're going to talk about across the board with a lot of these drugs, but important to keep that in mind is always why you want to do your baseline labs to see after you do start therapy if some of that might be occurring. Again, we talked about blocking dopamine in the tuberoinfundibular pathway, so we want to make sure that if you do have somebody on one of these drugs, you're not particularly going to draw a prolactin level for no reason. But if the patient ends up having, sexual dysfunction kind of going along with that being pretty high, gynecomastia, especially in our males, they usually don't like to grow boobies, then basically that's going to be something that I'm initially going to go ahead in those patients and draw a prolactin level, okay? When we're looking at thermoregulation, that actually can cause abnormalities of that as well. A lot of the time, it'll sometimes drop a patient's regular, 98.6 to being a little bit lower than that. It can cause seizures. Those that are known to have higher anticholinergic side effects have the greatest risk of that. So we're talking about our drugs like our thorazines and our thyroidazines have a greater chance of causing that. There has been reports of sudden death as well, that we're not quite sure if that's directly because of other issues with cardiovascular complications. There probably is some tie between the two. It's more than likely cardiovascular related that's happened. And then neuroleptic malignant syndrome. So neuroleptic malignant syndrome, you'll commonly hear that just referred to as NMS, so you don't have to come up with a big, long word when you're referring to it. It's pretty rare, but it's very lethal if it does occur. So it's something that you want to make sure you're also cautioning your patients on, at least letting know, doctors and other healthcare practitioners be aware of what it is and what to watch out for, especially in our acute settings. And basically, the symptoms of this are usually going to develop in the first 24 to 72 hours. Now, it's not to say that this can't happen with our atypical drugs, but it's much, much more common in our typical drugs, specifically our high potencies like our Haldol and our fluphenazines. And the mortality rate, again, is pretty high. Those that do develop NMS, especially if it's not recognized, which a lot of the time it is missed, is between 20 to 30% in older studies. Because it is something that's a little bit more recognized in the last 10 years, it's been a bigger push for having an understanding of what this is and how to manage it. It's about 10% still. So it's pretty scary to think that you still have about 1 in 10 patients, if it is developing, that will die from this issue. So, as you can see, there are a lot of symptoms involved. The confusion is going to be characteristic of all patients that develop this, and the increased muscle tone. So basically, if you have a patient that develops this, they stiffen up like a board, and literally, you can easily tell if it's MS because when you walk up to these patients, say they're laying in bed, I'm going to pick up their arm, and it's not going to go down. It's like stuck. Okay. So as you can imagine, that kind of goes along with that muscle rigidity, because what happens is the muscles are rubbing together so much that you are going to see a temperature. The patient's going to be febrile, and it's not going to respond as well to our normal antipyretic therapies, say like your Tylenol and ibuprofen. Okay, what we're going to do in terms of treatment for this is we're going to be looking at discontinuing right away any neuroleptic that they're on. So atypical, typical, doesn't matter. You're getting them off. Anything that could potentially be adding to that. You're going to start using dopamine agonists right away. So this is the one time in our psych patients that we're not really caring if they're getting psychotic. We're going to make sure that we're loading them up with dopamine as much as we can. So we're usually going to give them, bromocriptine is the common one that's usually used for this, or dantrolene, and usually benzodiazepines because they have some of the effect to work as a muscle relaxant. You're always going to make sure, because of the respiratory risk, that you're dealing with the patient potentially being intubated if this occurs. As you can imagine, if they're unable to move, that's going to more than likely affect the breathing. And that and the cardiovascular issues that happen with it are the main causes of why the patient would die. So when we're looking at our drugs, okay, real easy for you guys to try and remember here. You've got your low to high potency. So high potency meaning 2 milligrams of Haldol is equivalent to 100 milligrams of Thorazine. Okay? So your low potency drugs, you can almost draw a reverse arrow of this, okay? And that will be your anticholinergic side effects. Okay? So high potency, high EPS, okay? Low potency, you're going to have high anticholinergic. Okay? And that basically overall, when you're looking at the equivalent dosages, is about where it is. The highest anticholinergic risk is the Belaril. Okay, so that's not really one of our favorite drugs, but it's interesting because you think about why is it that Thorazine is going to have less EPS than Haldol? Well, it makes sense because they have that high anticholinergic profile to it. It's got a broad receptor profile. If I were to show you guys, say, let's just look at Haldol, for example. So say we've got Haldol here. Haldol is pretty much only binding to, let's say this is D2 receptors, okay? When you're looking at Thorazine, it's binding to muscarinic, it's binding to anticholinergic, all those funky receptors, it's got receptors going, say, all the way around here that it's going to target, okay? So that's how you can try and keep that a little bit more straight in your minds. I wanted to mention to you guys last time, this book in particular, I got a copy of it in my office. I'm going to try and make copies if you guys would like. Of those of you that are visual learners, this is Stephen Stahl's book. I had you guys do the pre-reading on his stuff, so you can kind of see some of, if you're having a hard time grasping it, he kind of puts a lot of pictures to what we're talking about. It makes it a little easier to learn, specifically with the drug therapies, okay? When we're talking about our overall typical drugs, basically we normally think of Thorazine as being the gold standard. It's one of the first that was developed, and it is very effective in treating our positive symptoms of schizophrenia. Okay, I can tell you when I was working at the state hospital in the aggressive male usage unit, when nothing else was working, we were giving them Thorazine, and it was finally knocking them down. So it's one of those drugs that when all else is failing, we're still going to resort to it because of its efficacy in terms of its positive symptom management. When we're talking about the side effects, unfortunately, because of the fact that it does have a higher anticholinergic burden to it, it has some more cardiovascular complications likely caused as part of the issue with that as well. You do rarely see some hematologic issues, so again, you're going to make sure, just because even though they're rare, you're following up on them with a baseline lab profile, and say every couple of weeks after the patient starts therapy with this, that you're going to monitor those. So agranulocytosis, leukopenia, thrombocytopenia, and the hematopoietic structure disorder as well are things that you'll basically just watch out for on the CBC. Okay. You also can see cholestatic jaundice syndrome. So basically, the patient will start end up having like potentially the liver be affected and can lead to liver failure. Again, it's pretty rare, but it's something that you'll want to mention to the patients. You start noticing any symptoms of jaundice, or yellow of the eyes or skin, that they're aware of that. Mellaril, as I mentioned, it's the highest in anticholinergic side effects. It's not recommended for elderly patients specifically because of that, because as you guys know, we're not using anticholinergics in the elderly as much as possible, or anybody that's got cardiac arrhythmias. It's not going to be something you're going to recommend. Because of the fact it's highest in anticholinergic, as you would expect, it would be lowest in EPS among that drug class. This one is known to have a higher incidence of causing the pigmentary retinopathy, specifically if you're going above 800 milligrams a day. It's very common. So we should not be going above 800 milligrams a day in patients that are taking that. So it's something to kind of keep in mind when you're looking at a patient's drug profile, that's like something we're not going to go above. When we're looking at overall dosages, a lot of the times when you're seeing specific max dosages, it's because of specific issues like that. There are cases when we talk about our newer drugs, for example, Seroquel, that you'll see the maximum dosage of 800 milligrams, for example, and we'll go above that because we know that there's limited issues with doing that, and it can potentially show efficacy in some patients. But overall, if you guys are seeing me paying attention to listing a maximum dosage, it's specifically because I want you to know the side effect that's attached to that, and it's important for you to remember, okay? Overall, with doses, I know one of the big questions for exams is, do you need to know dosing? This is exactly what I'm trying to tell you right now. I'm not going to expect you to know, unless I'm pointing it out to you in lecture, every single dose that we're going to go through, but something like that you want to keep in mind, all right? Photosensitivity is pretty rare with this one. There's no parenteral forms. Again, because of just the burden that this drug has in terms of side effects, it's not going to be our first choice more than likely. And because of the cardiovascular complications that can occur with this, it does have a black box warning from the FDA. Loxapine is an interesting drug. Loxapine is actually one of those that if you dose it low enough, it almost acts like an atypical drug. And that makes kind of sense because our gold standard for atypical therapies when we get to it, clozapine, is it's actually a structural analog of loxapine. So as you kind of see, I have highlighted here, if you're dosing it at doses under 100 to 150 milligrams a day, it almost has some atypical features where it may potentially help with some negative symptoms, which is not something I normally want you guys to classify in terms of treating as a typical drug at all. But if you go above 150 milligrams, it's acting like any other typical, and a lot of the times we do need to treat at higher doses than that. So it's just kind of something that's interesting. Amoxapine is actually one of the active metabolites of this drug, and that's sometimes even used in terms of treating anxiety. By itself, it doesn't have a whole lot of anxiolytic properties, but it does, when they have taken the active metabolite, amoxapine, out, and you use specifically that, it can treat anxiety. So it's kind of something that when we're looking through drug therapies might be beneficial for those patients versus another. It does have moderate EPS, especially at the lower doses, compared to a lot of the other typical drugs. Doesn't have a whole lot of weight gain that we do have to worry about with some of them, so sometimes that's ideal. And just because of initial dosing, if we are trying to use it more like an atypical, you're going to start out pretty low at 10 milligrams twice a day, unless the patient is severely disturbed and for whatever reason you don't have other therapies, you'll start out at 50 milligrams a day. In terms of the next drug here, Moban, this one, in terms of overall seizure threshold, even though it's got some more anticholinergic effects to it it has less anticholinergic effects on it than, say, Thorazine. It does have less effect on seizure than we might expect if we're looking at the overall picture in comparison. This, of all the typicals, is the only one that's not reported to cause weight gain. So that, again, is something that if you have a patient that is obese or is very concerned about that, it's something to try to remember. Because it does have some issues with cardiovascular complications, if the patient has got cardiovascular issues, it's, again, like some of the others we discussed, a contraindication. Okay. The next one, perfenazine. You guys may hear me mention when we're going through cases that a lot of our atypicals have been compared to perfenazine in what's known as the Katie trial. There was a big, huge trial that went on in the early 2000s that basically compared perfenazine, which was a typical they picked, to the newer drugs and tried to look at overall efficacy. And what they found is in terms of treating the patient overall and symptom management, especially for our positive symptoms, that there is no superior benefit using the atypicals compared to perfenazine. It showed a lot of other things, but that's the main thing that you can kind of remember with perfenazine, that it kind of spoke for the typicals and saying, yes, they are just as efficacious across the board in treating the positive side of things, and potentially sometimes even more so if it's specifically looking at positive symptoms. Has some other indications for treating intractable hiccups, which is kind of an interesting fact to remember. If you do have a case coming into a hospital, if you have a patient with intractable hiccups, they'll sometimes use this for that. And again, not a preferred agent in our elderly, but if you do have to use it, you're going to titrate the dose at about 75% less of what you give everyone else. So stelazine, another typical. This one does have some anxiolytic properties to it. You're going to want to make sure that you're going to watch out for, similarly, the pigmentary retinopathy, and it does have a higher risk of causing hypotension. One of the things across the board with all of the antipsychotics, specifically most of the typicals, is you guys will hear orthostatic hypotension. So you want to caution your patients because of that. If they're getting up too quickly, that they it might end up having that orthostatic hypotension effect, and you want to caution them on that. In terms of non-psychotic anxiety, you can use this at lower doses, but it's not something at this point that we're really going to look at for treating most of those patients, for just anxiety issues. You want to think of this as something that you're treating overall the patient for psychosis, and there might be an anxiety component to it. That might be why you would choose this over some of the others. Okay? Thiafixine, this one does have high EPS involved in it, not as high as, say, Haldol or fluoxetine, but again, it's pretty high compared to a lot of the others in that class. Not too much to say in terms of specific differences with that one compared to the other ones that we've discussed. Overall, across the board, similar side effects for what we talk about in terms of our typical drugs. Prolixin and Haldol are the two that, if you guys are going to know your typical drugs and know them really well, besides Thorazine, that you're going to see most commonly. Okay? So you have to have a good understanding of Prolixin and Haldol in terms of their dosing, because you will definitely see this wherever you practice. Because they have a very high potency, again, the high incidence of EPS, up to 90% of patients may experience that. You're going to try and divide the doses a couple times a day to prevent the EPS from occurring. Remember, the higher the peak, the higher incidence you have of developing EPS. So you're going to want to make sure you're doing that. Because it does have some blood dyscrasia issues, you're going to try and remember to do regular blood counts on this. Now, it's not to say that, when a lot of these blood dyscrasias are going to happen, it's going to be when you're initiating therapy or increasing a dose. So then that's when you'll pay a little bit more attention to this. Overall, the incidence of all of them are pretty low, again, because we know they occur. It's something you're just basically going to monitor. It is available, this and Haldol are both available in a long-acting injection, which, if you can imagine in terms of our schizophrenic patients, is probably something we would like, because of the fact that they're not always going to be compliant with therapy. They're coming in to get their Haldol inject or their Prolixin inject shot, that that they're getting the drug and it's got longer-term efficacy. You have to have an idea of how to dose these. These are really important, guys, and you need to be very responsible for knowing how to dose that. So basically what you're going to do is if you have a patient who, let's say, is on 10 milligrams per day, so they're on 5 milligrams twice a day, or 2.5 milligrams QID. You look at the overall total daily dose. So if we're saying it's 10 milligrams a day, and as you can see here, the dose is equal to 1.5 times the total daily dose given every 2 to 3 weeks, what would the dose be? 1.25 times 10 is what? 12.5. So every 2 to 3 weeks, you're going to have the patient come in for a dose of 12.5 milligrams if their dose before they switched over to the deck was 10 milligrams a day. Now, you want to make sure whenever you're starting out with these therapies, because these need to build up in the body, that you're always going to supplement with the oral until they get closer to a steady state. So you're always going to give the oral dosage of the medication within the first week of therapy for those patients. Okay, so say I've got somebody on that specific dosage. I'm basically going to go ahead, continue to give them the oral for 1 week after I give the deck shot, and then you can discontinue it. Some people will do it even a little bit longer than a week until you've got 2 or 3 injections, because over time that steady state needs to build up with those injections. Okay. Similarly for Haldol, again, this one is very strongly bound to D2, so you're going to see the high EPS. It doesn't have as much of the other effects that you see with a lot of the anticholinergic issues, which kind of is associated with the pigmentation effects in the eye. And you see little cardiovascular effects there. However, I want you guys to remember, and the FDA came out with a warning letter, over the last, say, 30 years, there have been reports of cardiovascular issues, specifically torsades de pointe, which means that they're going into cardiac arrhythmia, and that's usually when it gets to torsades is something that the patient's going to die from. So because that came out, it's very rare that it happens. You can imagine it's often as we're using Haldol to say that there was actually 28 reports that came into the FDA over the last several years. Pretty low chance of it happening, but once the FDA letter comes out, you want to make sure that you're paying attention to that. So they found that doses over 30 milligrams per day of Haldol, or if you're giving an IV, you really should have that person on cardiac monitoring. Really important to remember. I can tell you when that kind of came down that I had to implement the hospital policy on that if we had somebody, even in the psych department, that was going above 30 milligrams a day, we were transferring from the psych department over to somewhere that had telemonitors, so they could do cardiac monitoring. So that's something that most of our psychiatrists wanted to avoid, and just make sure they didn't go above that. Okay. In terms of the decanoate form for that, you basically can remember when we get to that. The dosage that you really should pay attention to, okay? This one is a little bit different. This one's a little bit nicer in terms of not having to come in every 2 to 3 weeks. But it's going to be usually monthly, okay? You're not going to start out necessarily monthly, but once you get to the second or third injection, you're going to hopefully be monthly. So what you're going to do for Haldol is, say you're on 10 milligrams a day of Haldol, okay? You're going to times that by 10 to 15 times the oral dose, rounded to the closest 50 milligram interval. And you're going to start out by you're going to make sure the first shot you give is never above 100 milligrams, okay? Because you want to make sure that, especially if they're going to have an issue with it, you're not going through a dosage above that, all right? So you always, for fluphenazine and for Haldol, you're obviously going to want to make sure that you have the patient stabilized on oral therapy before you're going to give them something long-acting that's going to stay in their system, okay? But the initial dose, you're always going to start with 100. If your total daily dose would normally be above 100 in 3 to 7 days, you're going to continue to give them the remainder of that, whatever that dosage should be. So say, for example, they were on a total daily dosage of 20 milligrams. That would mean that the injection should be 200 milligrams. I would only give 100 milligrams, and then after the 3 to 7 day period, I give the other 100 milligrams. And then I can wait until the next injection, which would be usually 3 or 4 weeks. You guys can remember 4 weeks from then, okay? So a month from now. And you're always going to supplement with oral until the second injection. So I don't want you to be confused, though. When I'm talking about the second injection, say that this is supposed to be 200 milligrams. You're not going to count that technically the second injection being 3 to 7 days as a second injection. That's still part of the 200 milligram dosage. It would be at the month injection after that. You guys following me, or did I lose you?
From the first to the second.
So if I'm only giving 100 milligrams, let's just go with that, and I only need to give one injection. The second injection a month later, I'm going to supplement oral therapy up until that second injection. Okay? If I'm giving, say, more than 100 milligrams, their total daily dose is, say, 20 milligrams, right? If it's at 20 milligrams, I'm going to give the initial one of 100. 3 to 7 days later, I'm going to give the other 100. I'm considering that really like the first injection, because that's like the full dosage.
Second half of the first injection, then the clock
So
starts
then
ticking.
clock
on
starts
the
ticking
third.
from that. Right. 4 weeks, oral supplementation, and then you're going to go ahead and give that second injection, and you can stop the oral therapy. Okay? Now, the full benefit of this is usually going to take about 3 cycles of injections. So, usually by the 3rd month, you're getting to steady state, and a lot of the times that people will be resistant to necessarily do a dosage increase up until that point. So that's important to kind of keep in mind as well. If you guys are having trouble with this, we can play with it a little bit more later to help you nail that down. So let's look at our newer drugs now, our atypical antipsychotics. This, in terms of schizophrenia overall, has been shown to be the first-line therapy for what you should be thinking about because of the decreased issues with the EPS and some of the known cardiovascular issues that happen with the higher the cholinergic risks that are involved. Basically, when we're looking at this, though, you have to think about the metabolic syndrome issues, and we'll go through a real easy way to remember what those are. But basically, one of the ways you can remember from the best profile, having the least amount of metabolic syndrome, to the worst, okay? If you guys can remember overall your brand names, okay? There's a little mnemonic device to help you for studying. If you can remember your brand names, going from Abilify to Geodon to Invega to Risperdal, Seroquel, and Zyprexa being the worst. Zyprexa is the worst offender in terms of metabolic syndrome. You can remember those. The lower in the alphabet, the less of a chance to cause metabolic syndrome. The higher in the alphabet, you're going to have a large percentage of your patients develop metabolic syndrome. Again, remember, metabolic syndrome increases in blood glucose, increases in blood pressure, increases in weight, okay, and increases in cholesterol. So not good things. So they're not going to cause EPS, but they're going to probably kill you in another way. Okay? So again, Abilify has the lowest chance of causing that. If I actually have had patients on Zyprexa that have developed metabolic syndrome, switching them over to Abilify, we've seen it actually reverse. That it can actually help out with that. But you're always, because of the fact it's an atypical, it's going to be something you're going to monitor across the board in all your patients. So getting back to one of the pre-reading assignments, all antipsychotics block T2 receptors in the brain. Atypical antipsychotics differ from conventional or typical antipsychotics in that they also block which receptors? I know I mentioned it being in class too. Serotonin, right? 5-HT2A receptors, which likely reduce the risk of EPS and improve negative symptoms of schizophrenia. So this is why, specifically because of those 5-HT2A receptors, that again, it's thought to improve some of the negative symptoms. What makes an antipsychotic atypical? Again, we've talked about lower risk of EPS, lower risk of prolactin elevations. The greatest risk among all of them to cause increase in prolactin would probably be coming from Risperdal, because that drug in particular binds to D2 more than the rest of the atypicals do. Okay, so you can kind of remember that's something you'll monitor a little bit closer in terms of your Risperdal patients. They can improve cognitive deficits in schizophrenia to a certain extent. There's been some studies that have been positive for that. There's been some that have been negative. Overall, because of because of not having as much of the anticholinergic burden that, say, a lot of the typicals do, that's probably part of the reason for that. Looking at your dopamine receptors in terms of specificity, they're going to block, more specifically, the dopamine receptors, not so much in the nigrostriatal area, but more so you'll see it in the mesocortical and the medial limbic areas. So knowing that it obviously can still affect cognition, but it's not going to be nearly as much as, say, our typical drugs do, okay? They do have black box warnings against them, specifically because of elderly patients that do have dementia-related psychosis, so a lot of our Alzheimer's patients, that you do have to use antipsychotics in them often because of become hostile and aggressive, and those patients that we do have to use them in, there has been an increase in morbidity and mortality. Knowing that, we're still often going to use them a lot of the time because what's better? Somebody that you can give, say, a dosage of Seroquel and keep them at home with their caregiver a little longer, or have them be completely unmanageable and have to institutionalize them, right? So it's just knowing that when that's done, that it's a black box warning that you do need to know to counsel your patients on, okay? One of the things that's kind of unique with our atypicals, again, is, less of, some have less of an effect than our other typical drugs in blocking D2. You need to know, in terms of any antipsychotic, you have to have at least 65% blockade on those D2 receptors to have efficacy as an antipsychotic in terms of helping out with the positive signals. If you have too much, though, is when you start seeing the EPS. So if I have a patient that I'm really concerned about EPS, or for example, I have a Parkinson's patient, and that Parkinson's patient becomes psychotic, okay? I'm looking at the two that are never going to do that. Clozapine and quetiapine have the lowest chance of causing EPS of all the drugs, okay? Olanzapine, diprasidone, and risperidone can exceed that depending on the dosage. Again, Risperdal of the three is probably the greatest risk because it is the strongest D2 drug, all right? One of the theories that your article definitely went into describing was the transient blockade. One of the reasons you think atypicals have less of a chance of causing EPS is specifically because of this transient blockade. So they'll go and they'll bind to the site, which exerts the antipsychotic action, and then they'll break apart and won't stay there permanently, say as much as a typical would, where they're binding and they're not moving, okay? So that's thought to be part of the reason why we see less EPS as well. When we're looking at the molecular structures and the drug potency, clozapine has 100 times less receptor affinity than Haldol for that D2 site, so that does tell you something. And that doesn't necessarily mean it's less effective as an antipsychotic. It is probably one of the best tools that we have in terms of treating patients. Unfortunately, it has some of these side effects, but that does have some issue to speak to how the drugs actually work, okay? When we're talking about the compliance of patients, 40% of rehospitalizations are due to medication noncompliance. So because these drugs are expensive and we know that they work better, doesn't always mean that it's going to matter if we're not taking them. So we have to deal with that, and there are medications that are being developed, for example, Risperdal, haloperidone, which is Invega, and Zyprexa have come out with depot injections to help out with that. And looking at, overall, we talked about the metabolic syndrome. If you're having a hard time remembering that, we've got that spelled out where all the criteria are. Basically, if you meet 3 of the 5 criteria, you're diagnosed with metabolic syndrome. So you might just have somebody that specifically has high cholesterol and is overweight, but doesn't necessarily have, say, hypertension or diabetes. And because of the high cholesterol being known as a major factor, if you have an HDL less than 40 in males or less than 50 in females, and the triglycerides above 150, and then, say the weight circumference, you meet 3 criteria, you have metabolic syndrome, okay? It's also something you need to take into effect that if someone's on medication for it, that counts as criteria, okay? So, meaning that if you have somebody that, is taking metoprolol, their blood pressure might be very well controlled, but of course that still meets them under the criteria for metabolic syndrome, okay? So looking across the board, again, at all our antipsychotics, we've had a couple new ones that have come out in the last few years. So iloperidone, Fanapt, is kind of falls in between where you see probably your paliperidone and your Geodon in terms of EPS issues. If you're trying to, think of Risperdal having the greatest chance. When you're breaking it down in terms of med chem, you're going to see that you've got your idones, okay, class, and then you've got your heme class. In terms of side effects, it doesn't always correlate to side effects overall. So there's been some issues in the past with people getting confused on that. Just try and stick to, other mnemonics. The med chem part doesn't play as much of a role there, okay? And when you're looking at your overall dosages, this is just a nice little chart that I put together for you guys that you can look at your usable dosages and your maximum dosages for these. Keeping in mind, there's specific ones that we need to pay attention to for maximum dosages. One of those is clozapine. When you get over 900 for a dosage, the dosage for clozapine almost correlates to if you were to do clozapine blood levels. So you almost have to get between 300 to 350 to see the drug be efficacious at all, okay? And then if you go above 900, you're usually going to end up with a level of side effects that increases, especially for cardiovascular issues, it's much higher. So you want to make sure that one in particular you're paying attention to. Among the rest of them, quetiapine is one of those I mentioned. 800 milligrams is the maximum dosage. That one we know clinically will go up to 1,200 milligrams. And most psychiatrists are comfortable with doing that because the side effects don't tend to be that different between the 800 to 1,200 range. Ziprasidone is another one that clinically, and you'll actually see improved efficacy in many patients, that ziprasidone's maximum dosage you'll actually see go up to 240 milligrams. Okay? The rest of them, but you're not normally ever going to go above the max on those. For spiridone, I should mention, though you see the maximum dosage of 16 milligrams, you're not usually going to go above 8 just because of the EPS profile that happens. It starts behaving much more like a typical drug when you get to higher dosages of that. So we're typically going to see 8 be the maximum dosage in that. When they initially did the studies and the drug came out in the early 90s, because that was the first true grouping of what we looked at as our atypical antipsychotics, that drug in particular, they did the studies up to 16 milligrams, but again, now that we've had it out on the market a lot more, you're not normally going to go above that usual or oral dosage of 8 milligrams, okay? So clozapine is an atypical antipsychotic with minimal to no EPS. The other atypical antipsychotics reported in the article to have no more EPS than placebo is, what? Quetiapine, very good. So hopefully you guys can remember those. I'm going to kind of go through the drugs fairly quickly, just pointing out the major side effects that you really need to know and those things that you need to be aware of. So I want you guys to, get comfortable going through and getting an understanding from further, obviously the indications and those things. But for example, with the Abilify, one of the things I want you guys to remember is, out of all the atypical antipsychotics, this one interestingly causes akathisia in a large number of patients that will go on it, especially when you're getting to the higher doses or going above maximum dosage. In most patients, they will experience potentially insomnia from this. Some might get sedated, some might get insomnia. It has a higher incidence of causing insomnia. So we usually recommend giving this one in the morning versus night, unless we know it is in the morning. It makes you tired. So it can go either way. It's generally known to cause a little bit more insomnia than sedation, though. This one is interesting because if you look at the mechanism of action, though we call atypical antipsychotics kind of the second generation, this one is almost known as a third because it's a partial dopamine agonist, meaning that depending on the level of a person's body, it almost kind of responds somewhat to that. So it blocks the dopamine receptors in one area, but it's a partial dopamine blocker, so it doesn't exert the same amount, which is probably why, if you're looking across the board at side effects, this one has got like the lowest of all of them, okay, in terms of EPS side effects if they were going to occur. When we're looking at our next one here, Sofreece, you guys really only need to worry about using this one in an acute care situation. It's not something we use for maintenance. So this is only if you have a patient, for example, who is needing something for acute therapy only. It's orally disintegrating tablet. It's not something that you're going to see probably in a community pharmacy as much. You'll see it more so on the inpatient side because of the fact that, again, it's not approved for maintenance therapies. When we're talking about the next drug you'll see, clozapine, this one I want you guys to remember is the gold standard of therapy. If you have a patient that is treatment resistant to all those therapies and you're trying different things, clozapine is what you're going to go to, okay? They've shown that between 30 to 60% of refractory patients, meaning that they're usually failing 3 or more therapies. Some studies will say, 2 or more therapies, depending on the patient situation, you go to those, potentially. But 3 or more therapies, you're going to look at them as more treatment resistant, and clozapine is going to be effective in most of those patients. It's also been shown that because of our schizophrenic population having a very high suicide rate, that it has actually improved, and there's some studies out there showing that it has improvement with that as well. So that's kind of interesting to know if you have a schizophrenic patient that's had a suicide attempt. Sometimes, that might be one of those times that if they were on one therapy, I'd almost consider it sooner than later. One of the things that you guys need to be particularly sensitive to with clozapine is the side effect profile. It's extremely burdensome, so it's going to be very important when we're talking about dosing with this one, okay? You're going to start out low and go slow. There's actually a set regimen that you're going to start out this patient in. You're going to start out at 12.5 milligrams twice a day, and then you're going to slowly increase it up till you get to that 300 milligrams over 14 days over that titration. So you start at 12.5 milligrams, then you go to 12.5 milligrams, then 25 milligrams, then you go to 25 to 25, and you slowly creep your way up to the minimum that you see efficacy is, again, about 300 milligrams. Or plasma levels, you usually draw a level and make sure that you're about that 350 level mark. Okay? Again, when you're getting up to the higher side of the things, this is about 900 milligrams per day. You're going to make sure you're doing a blood level. Anything above 600 milligrams per day, kind of rule of thumb in clinical practice, is when we're typically going to do those and make sure that we're not going and putting the patient at risk for the toxicities of the drug. Okay? If you have a patient on this, they have to be registered. This is one of those special drugs that you have to make sure they're registered with the Clozaril National Registry. Now that it's available generically, there's actually 6 different generic companies, so whatever one that your pharmacy has, if you're going to be dispensing Clozaril, you have to make sure that the patient has their blood work before you're allowed to dispense that medication, and the Clozaril National Registry keeps track of that. Okay? So even after the patients have been on this, for the first week of therapy, you're going to have to do, for the first 6 months of therapy, you're always going to have to do weekly blood draws, okay? And then after 6 months, if there's no issues, then you can go to every 2 weeks. But you want to make sure that that's one of those that, obviously that's going to deter a lot of people from going right to this medication. The other being the nasty side effect profile, okay? So agranulocytosis is the biggest risk in why you have to draw the blood levels. You're going to look at the A and C levels, the absolute neutrophil count, and the white blood cell count. If it's going, to an area and it gets down, you are going to often hold therapy, and if it goes down too low, say below, say 4.5 for white blood cells, you're often going to discontinue the drug. Other major ones, especially that is important for titration, and actually if the patient stops taking therapy, you have to titrate them again, is the other risk of seizures. The seizure risk goes up with the dosage, okay? So actually in some VA healthcare systems, if you get up to a moderate, what they consider moderate doses between, let's say, 400 and 600 milligrams, there's been institutions that have actually given anti-epileptic therapy to prophylax against that. So especially as you look in the higher range here, the 5 to 14%, as you can imagine, that's patients that may not have ever had a seizure before, that risk up to 14% is pretty high. So if the patient stops therapy, say they were maintained on, 400 milligrams, and they've been taking it for a long period of time, they miss the dosage for more than 48 hours, You don't have to do the whole 14-day titration again, but you will still titrate them back up because of the risk if they go right back on that therapy. It's a much, much higher risk if they'll have a seizure because of that, okay? Also, the worst, you can put this one, I don't want you guys to think of this in that A to Z scheme I gave you for metabolic syndrome. Because think of this as last line almost, you can put this synonymous with Zyprexa, last in line for metabolic syndrome. It's one of the worst for causing metabolic syndrome in terms of the weight gain, the diabetes, the blood pressure, all that, okay? It also is known to have a nasty side effect of hypersialuria. So a lot of the patients that we have on this, I can tell you, when I was working at the state hospital, that patients that were taking this, nothing else was working. We had to give them Clozaril, and they just had constantly drool coming out of their mouth all day. They'd have walk around with a towel, next to them. They'd sleep with a towel on their pillow. The other is sudden cardiac death. This drug has 5 black box warnings, guys. It's got a lot of issues against it, but again, it's the most effective. So you'll end up going to it with, a lot of your resistant patients. The sudden cardiac death, interestingly enough, has been attributed to increased eosinophils. What do you guys normally think of when you think of increased eosinophils? Allergies, right? Or parasites is the other one. For whatever reason, we're not talking allergy levels here. Okay, we're talking eosinophils in the thousands that'll come up on your blood draw. They won't be having allergies that they're showing, but for whatever reason, if eosinophil levels are high, it's been correlated to cardiovascular death. Okay, so if I have a patient on this, when I'm drawing that, the CBC to look and watch out for the agranulocytosis, I usually try to make sure I'm taking a look at the eosinophils in terms of that chemistry as well, to just kind of have an idea. If they're, getting up into the hundreds, that's going to be a red flag. If they get into the thousands, especially above that, you're really going to start considering, okay, this is highly correlated with sudden cardiac death, and I might want to take them off that medication, okay? Iloperidone, again, one of the newer ones that's been approved. It's only approved for maintenance of schizophrenia in adults, where a lot of the other ones that, as we're going through, you'll notice are approved for bipolar as well. It's kind of one of those Me Too's that came out. Nothing super special with it. Its efficacy is about the same. Overall, not too notable. Side effects overall similar to a lot of the rest of them, with the exception of, because it is probably just below, Risperdal, we'll talk about Risperdal in a minute, but Risperdal, as I mentioned to you guys, is the strongest D2 binding. Haloperidone is 9-hydroxyrisperidone. It's actually the active metabolite of Risperdal. This one it would be Risperdal, haloperidone, and then Fanapt in terms of EPS. That would kind of come in underneath that. So as you can imagine, the prolactin levels are known to be increased with that, probably third in line to the Risperdal haloperidone drugs. Okay. When we're looking at Zyprexa, as I mentioned, this one is the worst for metabolic syndrome, kind of synonymously again with the Clozaril for that. But because of the metabolic syndrome issues, it is one of those drugs that it works really well in our patients. The drug itself is very efficacious, but again, the nasty side effect profile is going to limit it. Specifically in your children and adolescents, because of the weight gain and hyperlipidemia that we've noticed in our adolescents, it occurs actually much faster in our children than our adults. It's going to be something that you're going to have to pay attention to, okay? Again, very effective, but this one, if you're going to give it, very, very, very high risk that they're going to end up having the metabolic issues. Does, remember, as I mentioned yesterday, has a strong interaction with CYP1A2, so that issue with the cigarette smoke, it can decrease the clearance by 50%. Similarly, I should mention when we're going through the other drug interactions, that one is one of the significant ones you should pay attention to. The other one would be for Risperdal, and we'll talk about that in just a moment. This one, as I mentioned earlier too, it does come available in a long-acting injectable form, the Zyprexa Relpra that came out a couple years ago. So another long-acting option for those patients, especially to help out with compliance. Okay. Risperdal Consta. So as I mentioned, Risperdal was one of the, Clozaril came out in the 70s, and they didn't quite realize that it was an atypical drug different from the rest of them. Kind of what happened in the early 90s when they came out with Risperdal, noticing that Clozaril was, effective, but they didn't like obviously a lot of the side effects. Risperidone came on the market, very effective. It's now available generically compared to all the other atypicals, of course not including Clozaril now, because that's older than dirt. But the risperidone, it's one of those nice options that we do have for patients now that, our atypical drugs are very expensive. They're all branded with the exception of this one. It is one of those that, especially in our children, because it's been approved for autistic disorder, that we will see be one of the first-line therapies if we do have someone who's an adolescent and we need to use it. It does have some interesting things when we're talking about the Consta. Okay, so the Consta is a long-acting injection, and what you see in the little diagram here, these are microspheres. Okay, so if you're giving Consta, it's not like the depot injections that you're going to give with the typical. The depot injections are oil-based forms. So basically, you're going to give somebody an injection, usually into the butt, and it slowly is going to release over a couple weeks. Okay. When you're talking about Risperidone Consta, it's not an oil-based form. These microspheres are what you see for the drugs. Okay. And basically, they're different sizes, right? So you're going to have some that are going to release a little faster and some that are going to release a little bit slower. And because of that, you can never split up an injection. For example, I might have a vial of Haldol that's got, 100 milligrams of it, and I only want to give a 50 milligram deck shot. I can do that. I can just draw up half the vial. If you're going to give a Risperidone Consta shot, it's important to remember that you're never splitting that up. You have to go by the exact dosage that's in that syringe to give the whole thing. Because you don't know if there's some of, the spheres that will be located in the first half or the second half of that injection. So you're giving the whole thing, okay? So Risperidone Consta, in terms of the dosage, you're going to give that every 2 weeks. And this does have an interaction with CYP2D6. So especially in drugs, for example, I can tell you often we'll have patients that are on, taking medication for depression and schizophrenia as well. So if I have a patient who's on Prozac, the CYP2D6 interaction and then Risperidone, that's actually going to increase the concentration of the Risperidone, okay? And you'll have the increased risk of the EPS and the prolactin issues and all that happen with that. So that's important to watch out for as well, okay? Moving on to our next drug, we already talked about the side effects for this a lot. So similar with a lot of the somnolence, GI upset and abdominal pain. Initially, with a lot of the drugs, if it's going to happen, you just basically titrate the dose a little bit slower. Again, the increased chance of EPS for this one, and the prolactinemia issues. When we're getting to Invega, again, this is kind of the baby of Risperidone. It's the active metabolite. So you're going to have pretty much the same side effects, with the exception of the EPS of this is pretty darn low because it's this really cool tablet formulation, okay? It's what's known as an Oros tablet formulation. And when we talk about ADHD, you'll hear about this again when we're talking about Concerta. But it's pretty interesting. If you look at the actual tablet, that tablet there, even though it looks like it's, just one tablet that you'd be able to break, you can't break it because what it actually is there's 3 chambers there. You've got the first one that is actually like where the water will go into and acts as like an osmotic pump to slowly go into the middle portion where the drug is and push it out the top over a 24-hour release. So what you get when you use this is a much steadier release of the drug. So remember when our EPS happens is usually during the peak. You don't have to worry about the peak and trough like you would give for example, of the Risperidone, where you're usually going to give that a couple times a day. You're looking at the half-life of Risperidone. It's about, 21 hours, so you really would have probably only have to give it once a day, but we're going to give it twice a day because of the side effects. Because this has that slow constantly, it alleviates a lot of that. And actually, they've shown that the 6 milligram dosage is almost equivalent to placebo in terms of EPS, issues, just because of the release of the drug. If you go to any dose above that, it goes back to normal. So you don't have to remember that in particular, but just know because of the release, you have much less of a chance of causing that the EPS side of things. Okay. This one is not a depot injection as well, similarly to the Risperidone Consta. This one is kind of nice because you give it once every 4 weeks, and you start out with a loading dose. So similarly with the Risperdal, with the Haldol, and with the fluphenazine injections, you have to give some oral supplementation for a couple weeks. Risperdal Consta, I should mention, you're usually going to give it for 3 weeks oral, and then you can stop it. This one you don't need to because you're going to give the initial dosage of 234 milligrams as a loading dose. And then 1 week later you'll go down to 156 and you can go down from that afterwards and then you go back up as you needed it, okay? So a little bit different. When we're getting to Seroquel, this one again is closer to Zyprexa in the alphabet, right? So higher chances of causing metabolic syndrome. This one, a lot of the times, this is the #1 prescribed atypical antipsychotic. Not so much because it's used as an antipsychotic, but because at low dosages, a lot of places will use it for sedation. Yes. The ghost capsule, okay. So the ghost capsule, I'm glad you pointed that out. The ghost capsule, because it's an orals formulation and it's got that osmotic pump, when you go to the bathroom, you'll actually see the tablet afterwards. So it doesn't actually, like most tablets, completely disintegrate in the body. It's actually, the capsule goes in looking similar to the way it comes out. So you want to let patients know about the ghost capsule, that they're not actually, pooping out the pill. It's going to be, because that's, the osmotic pump is the shell of it is going to come out.
Is there
Okay?
that formulation that's delivered to us?
That was just their marketing tool that, that they use for it. It would be helpful if they used it in a lot of the other ones, especially the ones that are, a couple times a day. Seroquel, for example, has a shorter half-life, and the immediate release half-life is only about 6 hours. The extended release is, interestingly, they say around 7 hours, but you only have to give that one once a day from the way it breaks down. So basically, when you guys are looking at Seroquel dosages, you're usually going to give that on average 3 times a day for the immediate release. We like to push people over to the extended release. It's about the same, and it actually can be a little bit cost saving. It's still, both of them are brand name only. We'll try and switch people once they're on, a dosage where they're above the 300 milligrams. We'll switch them over to the XR formulations. Okay. You can start them off on the XR formulation at 300 milligrams and still going up to the same target dose you would for the immediate release. You should be aware of the drug interaction with phenytoin. It can increase the clearance of this drug up to 500%, depending on the patient. So that's pretty significant, right? So you may need to increase the dose of quetiapine in those patients, especially beyond the 800 milligrams if you're looking at as a max. And just make sure you're watching out for the side effects. Overall, again, somnolence is probably the biggest issue with this drug, and again, you can give it at very low doses to patients for sleep. Not that that's approved, it's got so many side effects, we shouldn't be using it for that, but, in hospital scene, it does happen a lot. Geodon is the last one that, basically what you guys need to remember with this is this one can cause QTC prolongation, okay? So you're always, especially in our patients above, say, 40 years old, you're usually going to do a baseline EKG to make sure there's no issues. And if their QT is prolonged, you're not going to use this medication. Not recommended to use with other QTC prolonging agents. For example, when you guys learn about a lot of your antibiotics and other drugs that can do that because it increases the risk of the point. This one does have an active metabolite that can be a little bit more stimulating, so a little bit higher incidence of causing insomnia. Big thing with this is take it with food, guys. Its bioavailability is half of what it is when you take it on an empty stomach. So you want to remember, take it with food, not only because the GI upset is worse with this, especially if you're taking it on the stomach, but you take it with food, it improves the bioavailability and reduces the GI upset. So that's what you really need to keep in mind with Geodon. Okay?